Okay, assalamu alaikum everyone. My name is Mohammed Naem. I'm a third year medical student, and today I'm giving you a lecture about diabetes mellitus and metabolic syndromes. This lecture was given to you by Dr. Yaqeen, if I was not mistaken. And inshallah, it will be a very simple lecture. There's not a lot of complicated topics in it, but yeah, keep full inshallah focus with me, and inshallah it will be a piece of cake. So yeah, this is my name, this is my email, and this is my number if you want to contact me. Obviously, don't use the email, just text me on WhatsApp. It's way easier, unless you want to be very professional. But so, yeah, Annie, I give you the choice. So yeah, let's start. So first of all, before even we talk about diabetes, this is this line I'm going to tell you right now. It's a concept that I need you to have from now till you graduate. Okay, it's a very, 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 very important concept, which is the following: insulin is needed for glucose to enter the cells. If there is no insulin, or if insulin is not working for whatever reason, then glucose can't enter the cells, which will lead to high levels of glucose in the blood, because glucose is not leaving the blood into the cells. This happens when there's no insulin. So basically, insulin is acting like a key to the cell. It opens the cell so glucose can enter the cell. This is a very important concept. We're going to always go over it and over it through this lecture, and anything related to diabetes, to insulin, you're going to always hear the sentence. Okay? I hope this is very clear, because this is like basically the first brick we're going to put to build on. So let's start. So what is diabetes mellitus? Basically, diabetes is an impaired carbohydrate, fat, protein, basically all the metabolism in your body. This happens because of lack of insulin secretion, so your body is not secreting insulin, so you don't have insulin at all, or you have decreased sensitivity of the tissues to insulin. So what does this mean? This means that you have insulin in the blood. So your body is secreting insulin very normally, but the receptors are less sensitive to that insulin. So let's say you have 100 milligrams of insulin in the blood, okay? Now, if the receptors are fully function and there's full sensitivity, the cells they're going to sense that there is 100 milligrams. But if there's decreased sensitivity, the body will think that there is only 50 milligrams, for example, even though there is 100. But there is decreased sensitivity. So the body is gonna secrete more insulin, right, to reach that wanted level. So basically, diabetes mellitus is one of two cases. It's either we have decreased insulin secretion, so there is no insulin secretion, or there is insulin, but there is decreased sensitivity. So there is increased resistance. Another way, decreased sensitivity, increased resistance, the same. Okay. This is the basic definition. I hope it's very clear. And yeah, let's move on. Okay, so we have two types of diabetes, right? I'm pretty sure you guys heard of this a lot. Type 1 and type 2. Now remember, I told you diabetes is one of two cases, either decreased secretion or decreased sensitivity. Now, type 1 diabetes, it's the type where you have decreased secretion. Okay, now one of the basic concepts that I'm pretty sure you guys took, but if you didn't take till now, the pancreas is what secretes insulin, right? Now, what cells in the pancreas secretes insulin? It's beta cells. So what happens here? In type 1 diabetes, we have autoimmune antibodies. So we have autoimmune antibodies from the body itself, from the immune system. They go to those beta cells and they mark them and start attacking these beta cells and basically destroying the beta cells. So when this happens, we don't have any more beta cells, so we have no more insulin secretion, which would lead to diabetes. This is as simple as it can get. So type 1 diabetes, you don't secrete insulin. That's why it's called insulin dependent diabetes. That means you need to give insulin because the body has zero insulin. So you need to give insulin as a medication. Your body depends on insulin. So in this type, you have to give insulin as you don't have any insulin in your body due to beta cells getting destroyed. Okay, so let's move on. So again, as we said, these autoimmune antibodies, they mark beta cells, which lead to the destruction of beta cells. And now we have no to deficient production of insulin. At the start, it's deficient because not all beta cells are destroyed. But after 1 or 2 years, خلاص, all beta cells are marked, all beta cells are destroyed, so you have zero insulin production. Your body can't produce insulin because you have no more beta cells. This is type 1 diabetes. Okay, now for type 2 but diabetes, it's also called non-insulin dependent. What does that mean? That means you don't need to give insulin as a treatment in every case. Why is that? Because in type 2 diabetes, you have decreased sensitivity to insulin. Remember when I told you at the start, it's either decreased secretion or decreased sensitivity. In type 2, you have normal secretion actually, but obviously we're talking about the start. You have normal secretion, but you have decreased sensitivity. So your body thinks you have less your body thinks you're secreting less insulin than you actually are secreting. So what happens here? So we have high levels of blood sugar, right? And the pancreas is secreting insulin because of these high levels of blood sugar. Now the body have decreased sensitivity, so the body can't sense this insulin that is being secreted. So the pancreas will think, also the body will think that the pancreas is not producing enough insulin, so it will tell the pancreas, produce more insulin, more insulin. So at the start of the disease, in the very early stages, actually you will have hyperinsulinemia. So you will have increased level of insulin in the blood. So you will have more than normal levels of insulin in the blood. But the body can't detect this insulin. The body can't use this insulin, or it can use it, but to a lesser degree because you have increased resistance or decreased sensitivity. Is this clear? So at the start of type 2 diabetes, you have high level of blood sugar, right? And your body is secreting normal insulin. Now your body can't use all that insulin. So it tells the pancreas to secrete more and more and more. So you have now high levels of insulin and high levels of blood sugars in the early states. Is this clear? Okay, I hope it's clear. Now we're done with the start. At the start, high levels of insulin and high levels of sugar. Let's see what happens next.
I have a
Now,
question.
yeah, go on.
Yeah. What causes the reduction of sensitivity of insulin receptors? Like, what's the main cause of that?
There's multiple causes. Oh, first of all, it could be genetic predisposition. So basically, so you have a mutation in your genetics that makes you less sensitive to insulin. Obesity is a major risk factor. If you have more fat in your body, it technically makes your body less sensitive to insulin. So there's multiple factors that could lead to it.
All right. All right. Thank you.
Okay. Now we're done with the early stage. Now let's talk about the late stages. Okay, so now your body keeps telling the pancreas secrete more insulin, more insulin, more insulin. Logically, that couldn't be normal, right? Like logically, the pancreas won't be able to keep secreting extra level of insulin till ever. So the pancreas will get burned out. And when it gets burned out, that would lead to beta cells death. So now you're secreting more than normal for a long period of time. This will burn out the pancreas and the beta cells, which will lead to beta cells death. Now, remember what we said in type 1 insulin? What happens when beta cells are killed, or when beta cells are destructed? You have less insulin production. So in the late stages of type 2 diabetes, it becomes just like type 1 diabetes, where you don't have insulin secretion. Now, the problem is not just the sensitivity, but it's also that the body is not capable of producing more insulin because the cells are burned out and killed, or basically it leads to cell death. Is this clear? And I hope so. Basically, at the late stages of type 2 diabetes, it becomes insulin dependent diabetes. So now you need to give the body insulin because you have no more insulin as beta cells are killed, or there's no more beta cells because they are burned out. Okay. And I hope this diagrams help you to remember. So at the start of type 2 diabetes, your body, which is this guy, it's telling you, the pancreas, produce more insulin, produce more insulin. So you will have hyperinsulinemia levels in the early stages. Now, the pancreas can't keep up because it's not made to produce this much insulin over a long period of time. So after 1 year or after whatever time, okay, in the late stages of the disease, now the pancreas can't produce anymore this amount of insulin because the beta cells are dying because they are being overused. Now the body won't produce insulin as much as before, which would decrease the level of insulin, and basically you have type 2 diabetes, true, but basically you treat it the same that way, or not you treat it, but it's basically have the same presentation as type 1 diabetes, where you have decreased insulin and very high blood sugar. Is this clear? Okay. Okay. Okay, so this is the first checkpoint. I hope you all understood everything I said. Any questions, or should I go on? Okay. So this is our first question. Let's see if you guys can solve it. So 40 years old male patient came to for annual checkup. Okay, so he comes every year. Last year, he was diagnosed with type 2 diabetes. Okay, so we already know this guy has type 2 diabetes. His blood sugar levels were high and his insulin levels were very low. Okay, so he has high blood sugar and low insulin. Even though last year he presented in a hyperinsulinic state. So last year he had a very high level of insulin. This year, he has low levels of insulin. What explains this change? Is it A, the medication he was giving is working? That's why now he has low levels of insulin. Or is it B, because pancreatic beta cells failed over time or got burnout, as we said? Or because he actually has type 1 diabetes and he was misdiagnosed last year? Okay, I see B in the chat. Okay, that is true. It's actually B. Is this concept clear? Okay. Okay, I guess now. Great. So we shall move on. Okay. Now let's talk about diabetes manifestations or symptoms. Let's talk first of all about the acute symptoms. Okay, so now you have new diabetes in your body, so you will have new symptoms. Okay, symptoms that appear like 1 week after getting diabetes, 2 weeks after having diabetes, very acute symptoms. The first one, which is polydipsia, which means excessive thirst. And as you see from this picture, you need like basically these patients with diabetes in their acute state, they want to drink water all the time because they feel like they're always in thirst. Now, why does this happen? Let's talk about it in a physiological mind. Okay, so we said that you have high levels of glucose in the blood, right? What does this mean? It means that it increases the blood osmolality. Now, your body will think that the blood osmolality is high. That means I am in a basically in a I'm dehydrated. Okay, the body will think, okay, the blood is hyperosmolar. That means I'm dehydrated, which means I need more water. So it will trigger the thirst center in your brain, which makes you want to drink water. Now, the problem is, no matter how much water you drink, you're going to always have high levels of glucose in your blood because you're drinking this water is not really changing anything. Look, the glucose is still there, and your body will keep thinking that I'm dehydrated, I need more water, I need more water. So you're going to be always in excessive thirst. Is this clear? So the first symptom is polydipsia, and it's basically because we have high levels of glucose in the blood, which increases the blood osmolality. Any question about the first symptom and why does it appear? Okay. But let's move to the second one. The second one is also poly. So the first one was polydipsia. The second one is polyuria. What does polyuria means? It means excessive urinating. I'm pretty sure all of us have at least witnessed one diabetic patient in our families. But if you never did, then mashallah, you're lucky. But if you ever did, you notice that they always want to go to the bathroom. They're always in hurry to the bathroom. They go to the bathroom sometimes twice in 1 hour. Why is that? Okay, so remember when we said that there is high levels of glucose in the blood. Now, if you go back to the last semester and rethink about your renal block, if you remember very well, I'm pretty sure you took when there is high levels of glucose in the blood, there is a threshold. When you go over that threshold, the kidney can't reabsorb glucose from the urine. So this is the blood going into the glomerulus. The blood is getting filtered, right? And glucose is going into the lumen of the tubules. So basically into the urine. Now, the body reabsorbs glucose, right? And from the tubules, because we don't want glucose to go nowhere, because we need this. It's like it's basically an energy source. So we need this glucose. We can't make it go waste in the blood. I mean in the urine. So we want to absorb this glucose. But in the case of diabetes, you have such a high level of glucose that the body can't reabsorb all the glucose from the urine. So the glucose that are getting filtered is way higher than the capacity of the reabsorption of glucose. So you will have high level of glucose in the urine. What does this mean? This means it's going to increase the osmolality of the urine. So the urine is going to become hyperosmolar. What happens when the urine becomes hyperosmolar? It's going to attract water from the adjacent blood vessels. So more water is going to go into the luminal side of these tubules. So you're going to secrete more water and more Na and more potassium and more glucose in your urine. That's why they always want to go to the bathroom, and that's why they urinate way more than a normal person, because there's always excessive amount of glucose going into that urine, making the urine more increasing the urine osmolality, which attracts more water, so they want to go to the bathroom again. Is this clear? Is it clear why they have polyuria? Okay. So same thing. In the first one, it was because you have high levels of glucose in the blood, so hyperosmolality in the blood. This one, high glucose in the urine, so hyperosmolality in the urine, which means attracting more water. Okay, let's go to the next slide. The third symptom is polyphagia. Okay, what does polyphagia mean? It means increased hunger. So they have extreme hunger. They're always hungry. Why does this happen? Remember when I told you your body start losing glucose in the blood? And also the cells can't utilize this glucose. So we have high glucose in the blood, but there's no insulin, or insulin is not working. So the cells can't uptake this glucose. Remember, we said insulin is the key for the cells. Now, the cells are there and glucose is there, but there's no insulin to allow the cells to take all the glucose, which will make the cell, which basically means that these cells are getting no energy because there's no glucose coming into them. So they're sending signals to the brain that I need food, I need energy, I need ATP, even though there is glucose in the blood, but they can't absorb it. So they keep sending these messages to the brain that I need energy, I need ATP, I don't have enough glucose in me, even though there's a lot of glucose in the blood. Again, they can't absorb it. So the brain goes to the hunger center in your brain and again tells you that you're hungry, you need to eat, your cells are not getting enough nutrition, are not getting enough glucose. So they keep eating. They're always hungry. That's why a diabetic patient is always hungry. So this three symptoms you need to know: polyphagia, polydipsia, and polyuria. Okay? So they're always thirsty, they keep going to the bathroom, polyuria, they have excessive urinating, and the third one, which is polyphagia. Very, very important three symptoms. You're going to always see them in your MCQs. Clear till now? Okay. We have other symptoms which are more specific to a specific type of diabetes. Now, the first three symptoms, you see them in every single type of diabetes, okay? The first one, which is weight loss. Now, weight loss, you see it more in type 1 diabetes, okay? And we're going to talk about it more throughout the lecture. I'm not going to focus on it now. Just know that you see weight loss in type 1 diabetes. We have also another thing called diabetic ketoacidosis, which is a manifestation that we see in type 1 diabetes. And we have hyperosmolar hyperglycemic state, which we see in type 2 diabetes. We're going to talk more about these at the end of the lecture, so just keep them in mind. I'm not going to explain them now, okay? Now, with these six, we're done with all the acute manifestations. So we know what happens after 1 week of having diabetes, after 2 days of getting diabetes, you start getting not 2 days specifically, but you get what I mean. So in a short period of having the disease, you get these six symptoms, or you basically get the first three, and then you get one of these depending on what type of diabetes you have. Okay? Okay. So now let's go to the chronic types, okay? So chronic manifestations, the first reason, so what is chronic manifestations? Basically, it means the symptoms you have, or the manifestations that you have we have diabetes over a very long period of time. So we're talking about diabetes over 5, 6, 7 years, like every, or not just, maybe it could be even 2 years if not treated. So a very long period of time where you have very high level of glucose in the blood, it lead to these symptoms. The first one, which is non-enzymatic glycation of proteins. What does this mean? Okay, so think with me. This is the blood vessel. You have so much glucose in the blood, right? Now, usually for the glucose to bind to proteins, you need enzymes, basically to make this process happen. You need enzymes to make glucose bind to the proteins. But now, in the case of diabetes, especially in a chronic state where you have glucose such a long period in the blood, high levels of it, now, you don't need these enzymes anymore. Glucose can just go and bind to these proteins. Now, when glucose goes and bind to these proteins, it leads to a lot of problems. Now, remember, almost everything in the body has proteins. So the blood vessels, the muscles, uh, yeah, almost like literally almost everything in the body has protein. So if glucose keeps binding to these proteins, it can lead to a lot of devastating effects, such as what we're going to see now. So we have two main things that happen when we have non-enzymatic glycation of protein. The first one, which is small vessel diseases, okay? The second one is large vessel diseases. Very simple. So small vessel diseases and large vessel diseases. Now, what happens basically? Again, we said glucose bind to proteins. Now, what happens here in small vessel diseases is glucose is going to bind to proteins that make the small vessels, which will lead to a lot of problems. It could lead to atherosclerosis. It could lead to obstruction. It could lead to all of these things, which will make the blood vessel not functional, or which would basically. So, okay, let's think of it like this. We have the small vessel, right? The proteins in it is getting glycated, or glucose are binding to those proteins. Now this vessel is not functioning well, which means any organ here that's waiting for the blood to reach is not going to get enough blood, or is going to get blood that is not good blood, or maybe even the proteins in those organs are going to get this glucose, and glucose are going to stop binding to this proteins on those organs, which would lead to these manifestations. For small vessel diseases, now, where do we find small vessels usually? Okay, in a lot of places in the body, but most clinically important places are the eye, which is the retina of the eye, and the kidney, the glomerulus. So in the eye, we have the retina, right? Now, if we have diabetes over a long period of time, these glucose is going to go and bind to the proteins in the retina, which will lead to a diabetic retinopathy, which is a problem in the eye where you can't see well. And now it could lead to blindness. It could lead to decreased vision in the eye, inflammation of the eye. All of this happens just because we have a lot of glucose binding to proteins in that area, which would lead to a problem in the eye. So in an MCQ or in an SAQ, it's going to be like this. A guy presented to a 17 years old patient who had type 1 diabetes, or a 65 years old patient who has type 2 diabetes, can't see. They presented to the clinic with a decreased vision, or with no vision. They're blind now. Why is this? Because diabetic retinopathy. Or they can come and tell you a case where you have a patient with very high level of glucose, and they were not diagnosed with diabetes, but they have very high level of glucose, and suddenly they can't see. Now, they will go back to the history, and they will realize that this guy has diabetes since like 7 or 8 years, and he has not been treated, which led to this diabetic retinopathy, which is glucose binding to the proteins in the retina of the eye, leading to this blindness. Is this clear? Okay. So this is the first one. The second one, which is very, very high yield. Okay. I'm almost sure you're going to get asked about it in this exam. If not this exam, then you're going to get asked about it in steps and all the board exams that you're going to do, which is diabetic nephropathy. Again, remember, you guys took renal, so I'm pretty sure you guys are familiar with the idea of the glomerulus. The glomerulus is a very small artery, right? A very small artery goes into the Bowman's capsule and then exits. So again, it's a small vessel. With long time of diabetes, this vessel can get damaged because of glucose binding to the proteins in this vessel. Now, this would lead to diabetic nephropathy. It could show as nephrotic syndrome, inflammation of the glomerulus. All these nephrotic, I don't think you need to know them. Just know that there are diseases in the kidney that happen, or diseases of the glomerulus. Now, in diabetes, when this happens, you're gonna see in the MCQ or in the question that there is high levels of albumin or protein in the urine. Why is that? So the glomerular is getting damaged because of diabetes, right? Because of high level of glucose. So the pores in the glomerular are going to become bigger and bigger and bigger, which lead to proteins getting leaked. Because I'm pretty sure you guys know this by now, proteins do not get filtered in the kidney. They just because they can't pass, because proteins are too big and their charge is negative, and negative can't pass through this. So what happens is, now, in the case of diabetic nephropathy, this glomerulus is getting damaged because of high levels of glucose over a long period of time. Now, these pores are becoming bigger and protein is leaking. The major protein in the blood is albumin. I'm pretty sure you know that too by now. So you're going to find one of the findings in your MCQ that this patient presented with 20 years of diabetes, and suddenly he had, or not suddenly, but he has very high levels of protein in the urine. Why does he have that? Because
I think I think it was my connection. No problem. You can continue.
okay. So is diabetic nephropathy clear? Please, guys, if you see a case of someone who has very high level of glucose, or they tell you already that he is diabetic, and then they mention that he has high levels of protein or high levels of albumin in the urine, that means he has diabetic nephropathy. You're gonna get asked about it. I'm 100% sure. Like, it's very high yield. Is this concept clear? Okay. Now we're done with small vessel diseases, right? So we said small vessels, they could be in the eye, retinopathy, or the glomerular in the kidney, so will lead to nephropathy. Now, what about large vessel diseases? Now, again, this one is more simple. So basically, you have large vessels in the body, right? Like the femoral artery, the popliteal artery, and glucose binding to those proteins can lead to atherosclerosis, which is basically thickening of the basement membrane, or thickening of the artery, or making the artery or the vessel more rigged. So basically, it's not stretchy anymore. It's not flexible anymore, which would lead to obstructions and thrombosis forming, and could lead to obstruction in the femoral artery, popliteal artery, etc. Okay, okay. I think this is very clear. So remember, when there is non-enzymatic glycation of proteins, it could lead to large vessel diseases and small vessel diseases. Okay. Now, let's look at the other thing. The second thing that happens when we have chronic diabetes, which is osmotic damage. What is osmotic damage? Remember when we said there is high levels of glucose in the blood? Now, this would lead to something called sorbitol. I'm pretty sure you guys took sorbitol. It's basically a compound that can come from glucose, that can come from glucagon, which is sorbitol. Now, this sorbitol is going to go and deposit in places in the body, okay, and a lot of tissues in the body. Now, the most two high yield places that you need to know, the first one, which is neuropathy, the second one, which is cataract. Okay, so in neuropathy, what happens is that the sorbitol is going to go and deposit in the nerves. Where does this usually happens? It happens usually in the fingers, at the tip of the fingers, and in the legs. That's why they call it glove and stocking distribution. So basically, just remember it. In diabetic neuropathy, you have this deposit in the nerves. So now the nerves can't function well. So you won't feel. So you have no. So you're gonna have sensory loss. So you're gonna find it in the case. The patient can't feel his toes, or the patient wouldn't feel when you press on his toe. Why is that? Because he has diabetic nephropathy. The high levels of glucose in the blood over a long period of time is actually affecting these nerves, So now there's sensory loss at the periphery of his body. Just remember glove and stocking distribution, very high yield. It makes it very easy to very easy to memorize. Now, in some cases of very severe diabetes where the disease is not treated, it could even lead to motor loss. But it's rare, to be fully honest. And I never saw that. I actually never saw it in a question. But the doctor mentioned it in his lecture, so I was like, I might as well put it. He might ask about it, but I don't think if he's gonna ask about diabetic neuropathy, he's gonna definitely ask about the sensory loss. Is this clear? Because this is very high yield too. Yeah, basically sorbitol is gonna accumulate in tissues, okay, because you have high levels of glucose. So sorbitol is also a type of sugar, so it's gonna accumulate in a lot of places. One of the places it's gonna accumulate in is nerves. Okay, so when it accumulates in the nerve, the nerve is gonna start losing its function, right? Which will lead to sensory loss and sometimes motor loss, but it's less likely. Okay, but okay. Now, what is cataract? You see this eye? I'm pretty sure it's very clear that there is a cloudy area in the lens of the eye. Again, what happens is sorbitol or sugars is gonna come, or sugars in general, but mostly sorbitol is gonna come and accumulate at the lens of the eye, leading to cataract. As you can see here, uh, I'm pretty sure you guys saw a lot of those videos where they do surgeries. It's a very cheap surgery that is life changing because at this stage they can't see anything, but they just replace the lens, and it's very cheap. And now they can't see again. It's a very cheap surgery that people do. Now, I'm pretty sure you guys saw those videos, giving people their sight back and something like that. Yeah, basically they have cataracts and they do that surgery. So one of the reasons why people get cataract is because they have high levels of glucose, aka diabetes, over a long period of time, aka chronic. Okay, second checkpoint. Do you guys understand? Is everything clear? Any questions? Okay. Okay, let's solve this question together. A 65 years old female diabetic patient presented with cataract. Her blood levels are 3 times higher. Okay, I forgot to write higher, but 3 times higher than normal. And she hasn't been taking her medications for the past 3 years. Her urine analysis showed proteinuria. Which of the following is true? A, she has a diabetic nephropathy, which is leading to her cataract. B, she has diabetic small vessel diseases, which leads to proteinuria. C, the patient probably have no issues in peripheral sensory. A. Okay. Uh, any answers other than A? Okay. So it's not A, it's B. Let me explain why it's not A. Remember when we said diabetic nephropathy? Okay, diabetic nephropathy, remember, it's related to the level of protein in the urine because nephropathy, it's in the kidney. Cataract is in the eye. It's because of the accumulation of it's because of the accumulation of protein of sorbitol in the eye, right? So diabetic nephropathy, yes, she has diabetic nephropathy, but it has nothing to do with cataract. So the start is very true. This is so from the part of she till nephropathy, it's a true answer. But does diabetic nephropathy lead to cataract? It doesn't. They are not related. Now, when you go to B, she has a diabetic small vessel disease, which is basically the bigger name of diabetic nephropathy, which lead to proteinuria. So B is the right answer. C is definitely wrong. So yeah. Is it clear why is it B, not A? So yes, she has diabetic nephropathy, but it's not related to cataract. Okay. Good. It's a little bit confusing, but sometimes the doctors bring questions like that. So yeah, يعني, I have to put a hard question or two to make sure you guys are prepared. طيب. Again, B is the right answer. Okay. Now let's actually compare between type 1 and type 2 diabetes. Okay. So first of all, as we said regarding the pathogenesis, in type 1 diabetes, it happens because there is antibodies versus beta cells. Now, what type of antibodies? These antibodies are called glutamic acid decarboxylase antibodies. This is very, very, very high yield. You need to know this. Glutamic acid decarboxylase antibody. It could come in SAQ, it could come in MCQ. They could ask you about what type of antibodies that lead to type 1 diabetes, talk about the pathogenesis of type 1 diabetes. It's basically because glutamic acid decarboxylase antibodies attack beta cells, which lead to type 1 diabetes because they lead to the destruction of beta cells, as we said earlier. Now, in type 2 diabetes, as we said, there is insulin resistance for whatever reasons, obesity, genetic factors, uh, and so many other diseases, alcohol consumption or whatever, okay, which would lead to production of more and more and more insulin, leading to beta cell failure. Okay, so we already explained this. Let's move to the next point. Okay, in type
Uh,
1
can you
diabetes,
can
yeah,
you re-explain the diabetes one part in the previous slide?
okay, okay, sure. Okay, so in type 1 diabetes, remember, we said that you have antibodies that goes and bind to beta cells in the pancreas, which lead to the destruction of these beta cells, right? Now, what are these antibodies? They are called glutamic acid decarboxylase antibody. It's this simple. Antibodies, autoimmune antibodies from the body itself are going to go and bind to beta cells, attack beta cells, and lead to the destruction of beta cells. So now you don't have beta cells, so you don't have production of insulin. As simple as that. So you have no production of insulin. In type 2, you have insulin resistance. So there is insulin. Beta cells are at the start, beta cells are actually producing more insulin than they should because the body keeps telling them produce more insulin, produce more insulin till the beta cells fail and die. Is it clear the difference? So one is related to antibodies, the other one is related to insulin resistance or insulin decreased sensitivity. Clear? Okay. Now, the second point is, remember when we said type 1 diabetes, there is no beta cells. Beta cells are dead now because of the antibodies. What does this mean? That means we have no insulin in the body, zero insulin, zero production of insulin. Now, sadly, our bodies can't, like, the human body can't uh, function without insulin. You need insulin for so many other things other than glucose. Like, obviously, glucose is the main one, but we're gonna see by the end of the lecture that we need insulin for many other diseases. Okay, so or for many other things, for many other physiological functions in the body. So in type 1 diabetes, we have no insulin at all, so we need to give insulin. The patient can't survive if we don't give them insulin. So always insulin is needed because the body can't produce insulin. So we always need to give insulin as a treatment. Now, in type 2 diabetes, sometimes insulin is needed, which is in the cases where we are in a very, uh, very late stage of the disease, where the patient actually can't produce insulin, or most of their beta cells are destroyed, are fatigued, are burned out. So now we need to give insulin. For example, actually, a life example from my life, my grandma has type 2 diabetes. Now, at the start, when she was still young, she never took insulin. But now she's like 78, على طول بعمرها. But she's 78 and almost like all of her beta cells are destroyed. So she needs to take insulin after every meal or before every meal, whatever. So is it clear? So in some cases of type 2 diabetes, especially in the early stages, you don't need to give insulin. But in type 2, but in type 1, you always need to give because the body can't produce insulin and you need insulin. Is this clear? Okay. Okay. Now, another thing that you need to know and always look out clinical scenarios. Type 1 diabetes usually present in patient under 30 years old. Now, yes, like the book says under 30 years old, but in most cases, you're gonna get patients who are like 15, you know, a patient who's 15 who has a very high level of glucose, a very high level of blood glucose over like 6 months, and he's only 15 years old. That's in 90% of cases, it's type 1. Like it's very rare to find type 2 diabetes in young patients. It's almost always the old patients. So type 1 diabetes is always in younger generations. And like it's almost impossible to find type 1 diabetes in like someone who's 60 years old because it's usually a disease that starts at a very young age. So basically, as we said, there is no insulin production in the body, and this disease starts as a very young age. So if there's no insulin production, the human can't live till 60 if he's not really treated. So you can't discover type 1 diabetes when someone is 60 or 70. Now, I'm pretty sure there's always cases where they actually found that someone who type 1 diabetes started at a very late age. But for your cases, for your MCQs, you're probably not gonna get asked about someone who's 60 years old and he has type 1 diabetes. It usually doesn't happen. Like it's not common at all. It's very rare, almost impossible to find. So always in your MCQs, look at the age. If they're young, then it's most likely type 1. If they're old, it's most likely type 2. Not just that, also obesity. Now, obesity is a very major risk factor in type 2 diabetes, like very big factor. Like if you're obese, like the percentage of you having type 2 diabetes increases by like 10 times. It's crazy Aslan how much obesity affects diabetes because as I said at the start of the lecture, when you're obese, you have insulin resistance. So when you lose weight, actually this insulin resistance get decreased. And in very early stages of type 2 diabetes, most doctors actually advise their patient to lose weight. Try to lose weight. Why do you want them to lose weight? To be more healthy? Yes, but not just that. Mostly because when you lose weight, when you're not obese anymore, you have less insulin resistance. And actually a lot of cases are just treated by they lose weight and خلاص, their insulin resistance is gone and they can live without taking any medications, without taking insulin injections, without anything. خلاص, they lost weight, so insulin resistance is not there anymore. It's that simple sometimes in type 2 diabetes. What do you mean, but how? What do you mean, Bob? How is it cured يعني ولا how does losing weight decrease resistance? Okay. Basically, when you have increased level of fats in the body, right? And I'm not gonna go into the details why does weight lead to resistance because that's actually too complicated for you guys and it's way above your level for now. But basically just know the fact that when there's high level of fat in the body, right? So the body, just think of it like this. The body starts using this fat a lot as an energy source and yeah, it's like they they don't need glucose as much as you think they would, right? Now, because of that, you're gonna build resistance. So you want less glucose entering the cells. So because of this very high levels of fat, and because also this fact is going to actually affect the receptors of insulin, like there's multiple factors, but basically just know that high levels of fat or being obese increases the resistance. Now, when you lose weight or you decrease your weight, this factor is not there anymore. There is less. No, no, it's not like that. They always need glucose. They always need glucose. But no, it's not like they don't need insulin because they need insulin. Everyone need insulin. But let's say to a less extent, they need it to a less extent because again there's another energy source and not just that, but also fat itself. Okay, fatty acids as basically as fatty acids themselves, they affect the insulin receptor. It's not just about that. There's another engine energy source. No, Like fat itself affect the insulin receptors and make it less sensitive, like direct effect on the insulin receptors, if that makes sense. It's a very let's say complicated idea that also has effects in the genetics and whatever. So just don't really think, like don't overthink it. You can read it from the book if you want. I'm not gonna spend time on it, so I don't want to confuse anyone. But yeah, just for now know that when you're obese, you build resistance to insulin. When you lose weight, this resistance go down. So now you're more sensitive to insulin, if that makes sense. So again, a lot of patients in very early stages of diabetes, when they go to the doctor, they don't give them medications and they tell them to try to lose weight. Because if they lose weight and this resistance is gone, خلاص, there's no more diabetes. Their blood levels are normal, insulin is working well, and it's cured. Okay? Is it clear now? Okay, great. Let's move to the next point. Okay, so type 1 diabetes have a weak genetic predisposition. What does this mean? It means if someone in your family has type 1 diabetes, it does increase the risk of you having it or your son having it. If you have type 1 diabetes, yes, it does increase the risk of your son having type 1 diabetes, but it's way less than if you have type 2 diabetes. That's why whenever you go to a doctor, they always ask you, does anyone of your family have type 2 diabetes? Because type 2 diabetes have a very strong genetic predisposition. So the moment there is someone in your family who has type 2 diabetes, it increases the risk of you having it by like multiple times. So just know always when we're talking about type 2 diabetes, family history is really, really, really important. That's why when you find someone who has diabetes and you actually ask him, most of the time you find that his dad has diabetes, sometimes his mom has diabetes, sometimes both of them, right? So type 2 diabetes, it's really when you're looking for type 2 diabetes or even type 1, always ask about family history, because if there's a lot of family history, then it could lead you to the fact that it's type 2 diabetes. Okay? Now that's the first thing. The second thing, the association with HLA-DR4 receptor. Now in type 2 diabetes, there's strong association with the HLA D4 system. In type 1 diabetes, there is no association. Now, I can't come and explain this HLA system. It's gonna take me like a long time, and I watched the recording. The doctor just mentioned them, so I'm pretty sure you guys don't need to know them for now, unless they're mentioned in another lecture. If they are mentioned in another lecture, then definitely know them. But in the context of this lecture, just know this fact: Type 2 is related to HLA D4 DR4. If it's gonna come in a question, it's gonna be like this: This patient has a problem in DR4. What does he have? Type 1 or type 2? It's going to be type 2. Okay? Because type 1, it's not related to this system at all. Just, صراحة, just memorize it. Like, don't go into details. I advise you not to go and read about this system because it's kind of complicated. Again, if you took it in a different lecture, then this is a different case. Definitely go read about it and know it. But for the context of this lecture, no need. Just know that type 2 is related and type 1 is not related. Okay? Is it clear till now? Okay, good. Okay. In type 1 diabetes, we have severe glucose intolerance. What does this mean? That means if we're going to put glucose in the body in type 1 diabetes, in a patient of type 1 diabetes who's not treated, so we're not giving them insulin, okay? Just someone who has the disease and not treated. If we give them glucose, they have very severe tolerance. What does that mean? That means their body can't take this glucose. The body can't use this glucose. Why is that? Because there is no insulin. There is no insulin to let this glucose inside the cell. Remember, insulin is the key for glucose to get inside the cell. In type 1 diabetes, we have no insulin, zero insulin. So when we give glucose, basically, when we give glucose, insulin is not there to utilize this glucose. That's why glucose is intolerated in type 1 diabetes. The body can't use glucose. Okay? And there is very high insulin sensitivity, which means when we give insulin, the insulin is going to be actually utilized, unlike type 2 diabetes. The sensitivity is normal, The problem is that are not producing, uh, we are not producing insulin. That's why, remember when we said before 2 slides, we always treat with insulin because insulin is perfect for type 1 diabetes. There is decreased production. If you give insulin, you solve the whole problem. خلاص. Like basically you solve the disease. It's a very simple disease. That's why actually a lot of people who have type 1 diabetes, if you detect the disease very early and you start giving them insulin with the right doses since they're young, they're gonna have a very, very normal life because they're just taking the insulin doses that they need and they live on. They have no insulin resistance, no other problems. خلاص, you give them the insulin that they need, and that's it. Unlike type 2 diabetes, which can't just be treated by insulin because there's insulin insensitivity, and actually there's also high levels of insulin at the start. So the problem is not the insulin in type 2 diabetes. Okay. Now, in type 2 diabetes, there is mild to moderate glucose intolerance. What does this mean? It means that when you give them glucose, they can use some of that glucose and they can't use some of it because again there is a little bit of insulin or there is insulin, but this insulin is not fully utilized because of low sensitivity. So when you give glucose, yes, the body can use this glucose. It can't use all of it because we have low insulin sensitivity, so not all the insulin in the body is working because the receptors are insensitive to it, but some of them are working. That's why there is mild to moderate glucose intolerance, unlike type 1. Is this clear? Any questions? Okay, great. Okay, now you need to know this. In type 1 diabetes, there is something called ketoacidosis. The moment that you see high levels of glucose with ketoacidosis inside the case, 90% of time, like 99% of the time, it's type 1 diabetes. It's very, 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 very rare to find type 2 diabetes with ketoacidosis. Like almost very rare. And when it happens, the ketoacidosis is usually due to a reason other than diabetes اصلا. They have like another syndrome, another diseases that is leading to ketoacidosis other than diabetes. But the moment that you find ketoacidosis in a case with high levels of glucose, young age, then just just pick type 1 diabetes. It's that simple. Young age, ketoacidosis, it's almost always type 1 diabetes. Okay? Now, what is ketoacidosis specifically? I'm going to talk about it later in a different slide. But for now, just know this fact. Ketoacidosis almost always means type 1 diabetes. Almost always. Not every case, but like 99% of cases. Okay? Okay. Now, in type 1 diabetes, you have low number of beta cells. As we said, because the beta cells are attacked by the antibodies, so they're all dying. And you have low levels of insulin, again, because the body cannot produce insulin as there is no beta cells. In type 2 diabetes, there's variable numbers of beta cells and variable levels of insulin. يعني okay, I don't know why I wrote low levels of insulin. It's actually variable levels of insulin. My bad. I have to change this because in type 2 diabetes, it depends on where, like, when did you detect, in which stage did you detect the disease. If you detect it at a very early stage, you're going to have high levels of insulin and good number of beta cells. If you detect it at a very late stage, you're going to have very low levels of insulin and very low number of beta cells. So type 2 diabetes is very variable. It could be high number of cells or low number of cells, high level of insulin, low level of insulin, depending on the stage. Okay, I need to change this. Please forget about the word low because it's a variable. Okay, before I send you the PowerPoint, I'm gonna actually change it if I remember it all. Okay, clear? Great. Okay, in type 1 diabetes, it's usually present with the classical 3 symptoms that we talked about: polydyspia, polyphagia, and polydyspia, polyphagia, and polyuria. Type 1 diabetes, usually when they come to the clinic, they come with these 3 symptoms. It's very clear. Now, regarding type 2 diabetes, now remember, as we told you, type 2 diabetes, the problem is not really in the insulin itself, it's in the resistance. So we still have, so in the early stages of the disease, we still have insulin. The resistance is still not that bad. So the body goes like the body progressive, like the disease is very progressive. So at the start, you might have diabetes for 5 6 years without actually noticing that you have diabetes regarding type 2 because it's very progressive and it differs from one type person to another. So sometimes they present with these symptoms. Sometimes type 2 diabetes is actually detected just randomly. You go to the hospital for, you want to like transplant blood, you want to actually like blood donate, or you're doing tests for a different case, for like you have a broken arm, or you have like stomach ache, and you're doing blood tests, and then the doctor sees that you have high levels of blood glucose over a long period of time, using some tests that we're going to talk about, and then he diagnosed you with type 2 diabetes. So actually, a lot of the time, type 2 diabetes is actually found randomly, and accidentally, actually. Unlike type 1 diabetes, which because of the cells are dying very rapidly because of antibodies, so you have these acute symptoms appear very quickly, and it's very clear what you have. Is it clear? Now, again, these three symptoms, they could appear in type 2 diabetes. Remember, we said these three classical symptoms, polydysphagia, polyuria, and polyphagia, they appear in both types. But like in type 1 diabetes, it's always almost there. Like it's almost always there. In type 2 diabetes, sometimes it's there, sometimes it's not. And just for you to know. Like if you don't see these symptoms, don't exclude diabetes. Okay, it can't be type 2 diabetes because these three symptoms are not found in the case. No, it could be. Okay, that's what I want you to know from this slide. Okay, now let's talk about this. Okay, now most of actually the ideas of this in this slide I have already discussed, but first now let's talk about something about which is lipolysis. Okay, this is a fact that I want you to know. When there is low levels of insulin, or insulin is not working, but mostly when there's low levels of insulin, when insulin is not there, okay, it leads to increased lipolysis. Did you guys take what lipolysis is in first semester? And I think you took it in mol. I'm not sure you did. I actually can't remember if we take it in first or second semester. Did you take lipolysis? Okay, anyway. So basically lipolysis, it's the process of bringing a big fat cell or a big fat compound and breaking it down to free fatty acids. Okay, this is what lipolysis is: bringing fat tissue and breaking it down into free fatty acids. Now, this process increases when there is low levels of insulin. Okay, you don't need to know the reason why this happens. Just know low levels of insulin means increased levels of lipolysis, which means higher levels of free fatty acids. Now, the problem is specifically in type 1 diabetes, this lipolysis, you almost never have insulin, right? Because the body can't produce insulin. So lipolysis is always happening. So you're gonna always have free fatty acids in the plasma. And now you have excess of these fatty acids. So what's gonna happen to these fatty acids? Again, I'm not sure if you took this in mol or you're going to take it this semester, but if you didn't, these free fatty acids are going to go into something called ketogenesis. Ketogenesis is a process where it changes fatty acids into ketone bodies. Okay, ketone bodies, when they increase in the blood, they lead to what we call ketone acidosis, because ketones are like acidic, so they lead to what we call of ketone acidosis, which is it's a very severe complication that I'm going to talk about later in this. Okay, so we said we have high levels of lipolysis because of decreased levels of insulin. Now we will have high levels of fatty acids because of high levels of lipolysis, increased ketogenesis. Okay, now when you have high levels of ketones or increased ketogenesis, it's going to lead to vomiting. Okay, just for you to know, it's just pure fact. High levels of ketones, it leads to vomiting. It's like 1 plus 1 equals 2, something you need to know. Now, again, the increase when ketones increase in the blood, that leads to what we call of acidosis. anion gap metabolic acidosis. I'm pretty sure you guys took this in CVP. But anyway, it leads to acidosis. And as you guys took in CVP, when there is acidosis, it leads to what you call hyperventilation. Okay, so metabolic ketoacidosis lead to hyperventilation and vomiting. Okay, as simple as that. Okay, so you start hyperventilating. So basically taking higher number of breaths inside a minute, in 1 minute more than you actually should. Okay, so this is the first things that happen when there is no insulin, increase of lipolysis. The second thing, which is increased of proteolysis, which is the destruction of protein. Again, it's another thing that happens when there's no insulin in the blood. Why does it happen? Again, you don't need to know. Just know that there is increased lipolysis and increased proteolysis when there is insulin deficiency. Now, this is what leads to weight loss, the thing that we talked about before. Because of increased proteolysis, it leads to weight loss. Okay, so now we know from where do we get ketoacidosis, and we know from where do we get weight loss. Ketoacidosis happens from increased lipolysis. Weight loss happens from increased proteolysis. Okay. Okay. The rest of these are things that we already talked about. Decreased glucose uptake because there is no insulin. Insulin is the key to the cell. Increased glycolysis, which is again the body is not utilizing glucose, so the body thinks there is no glucose, so they start breaking more glycogen to get to have glucose more glucose in the blood, and increase the glucogenesis, which is the production of glucose, again, because the body thinks there is no glucose in the body, there's no glucose in the blood because the body is not utilizing it. So they keep increasing the amount of glucose in the blood, which would lead to increased hyperglycemia and glycosuria, which is basically high levels of glucose in the urine. Again, lead to thirst, hypovolemia, because of the diuresis that happens, as we said, the polyuria happens, could lead to hypovolemia. Now, in some cases, like very rare cases, if this hypovolemia is not treated, it could lead to death. Now, how common is this? I'm not sure, but I'm very sure it's not common. Okay, because again, it's a very slow process, and if you are not living in an area where you have no water or an area where there's zero medical care, dying from hypovolemia due to insulin deficiency is something that most likely won't happen. Now, will you get asked about it? I don't know. I don't think it's high yield, but again, just know it. If they ask you how could insulin deficiency how could diabetes lead to death, say hypovolemia. Ketoacidosis also could lead to death. So these two could be right answers. Now, is this graph clear? Most of it actually we talked about already, but these two, proteolysis and lipolysis, are new points. So are they clear? Okay. Okay, so now let's talk about some diagnostic tests. Regarding diabetes. The first test and the test that you need to know the most, which is HbA1c, the most important test regarding diabetes. Now, why is this test very important? First of all, what is it? Basically, it's a test to know the levels of glycated hemoglobin. So again, the same idea as glycated proteins. When you have very high levels of glucose in the blood, the glucose start binding to multiple things. It binds to protein, and one of the other things that it binds to hemoglobin in the blood, basically in the red blood cells. So when you have basically when you have diabetes, a lot of glucose is binding to these cells. So when you have higher than 6% of HbA1c in the blood, that's diagnostic for diabetes. Why is it directly diagnostic to diabetes? Because the fact it's a test that tests the levels of glucose in the blood for 3 months. Okay. Now you might ask, why is it 3 months? Because remember, basically the lifespan of an RBC is 90 days, is 3 months, right? So which makes sense. If these cells die after so these glycated cells, they have built this amount of glucose on them over 3 months, because more than 3 months, that means the red blood cells have been the cells died and there's now new cells, which means the blood was That's for more than 3 months. Less than 3 months is that's the less time from the lifespan of the RBC, so it doesn't make sense. So this test is perfect for long time diabetes, for chronic diabetes, uh, to actually know if the patient have diabetes or not, because it tests the amount of sugar in the blood over full 3 months, as we said, because it's the lifespan of hemoglobin inside the RBC. This is the first test, very important diagnostic test that you need to know. Okay. Okay. The second test is fasting plasma glucose, which means you tell the patient, come to the clinic fasting 8 hours. Okay, so the last 8 hours you don't eat anything. You drink water, but you don't eat anything at all. Okay, so 8 hours without eating anything, and then you test the plasma glucose. If the plasma glucose is above 120, this could indicate diabetes. You just need to know the values. I'm not sure if they're gonna ask you about values in first year, but yeah, just know these two tests, HbA1c is for 3 months. For fasting plasma glucose, know that they need to fast more than 8 hours. And to be honest, I suggest knowing the number. It's like three numbers. Just know them. Very simple to memorize. Now for the third test, which is 2 hour oral glucose tolerance test, which is what you do is you bring the patient and you give them 75 grams of glucose and water. And then you wait for 2 hours. After that, the you go and test the level of glucose in the blood. If it's more than 200, that indicate diabetes, because the body was not able to process glucose as fast as it should normally. If it was less than 200, then they should be fine, because they processed glucose as fast as the normal body should. Are these three tests very clear? Okay, the three tests are diagnostic. Three of them are very important to know. You're gonna probably find them in your MCQs. You could get asked about them in an SQ case, so please know them very well. They're very high yield. Okay? Okay. This is a checkpoint. Any questions? We're very, very, very close to finishing the lecture. We have just a couple of extra slides. So is everything till now clear? Yeah, okay. Great. Okay, now we have this question. 7 years old kid presented to the ER with polyuria and weight loss, with increased appetite. His blood glucose levels are very high. He has no family history of diabetes, and his HbA1c was 8%. What is your diagnosis? Is it type 1 diabetes, type 2 diabetes, or C, which is peripheral neuropathy? A. Okay, it's true. It's actually A. It's type 1 diabetes. But why did you say A? What are the indications in the question that led you to A? First of all, the age, 7 years old. So it's most likely not type 2, it's most likely type 1. That's one. Two, there's acute manifestations. That's true. There's acute manifestations. Polyuria, okay, and increased appetite, which is polyphagia, just written in another way, right? Okay. So how are we sure that he has diabetes? Because he has, so now we know he has polyuria and he has increased appetite and no family history. That is also true, because usually if it's type 2, there is family history. Third thing, he 100% has diabetes because he has high level glucose and his HbA1c is 8%. So we know for a fact he has diabetes. Which type? Everything is indicating till type 1. That's why it's A. Very good. Alhamdulillah. You guys are understanding. This is شيء مبشر. Alhamdulillah. Okay. Now let's talk about ketoacidosis. Now, again, I want you to remember, ketoacidosis almost only happens in type 1. Almost never happens in type 2 diabetes. Okay? So almost always type 1 diabetes basically have ketoacidosis. Now remember, why is that? Because when insulin is not there, it leads to increased lipolysis, which lead to increase fatty acids or free fatty acids in the blood, which get converted into ketone bodies. Ketone bodies are acidic. That's why it's called ketoacidosis, because the body become very acidic due to increased levels of ketones. Now, when you go to the lab and test a patient who has ketoacidosis, it's going to show hyperglycemia because again they have type 1 diabetes, they have increased levels of glucose and no insulin. That's why it leads to hyperglycemia. They're going to have high level of H plus because remember it's acidosis. So yeah, it's acidosis. That's why they're going to have high levels of H plus. They're going to have hyperkalemia, but the potassium is very depleted intracellular. Now, this is something that I need you to know, okay? It's not explained well in this lecture, so I'm pretty sure that was not the purpose of the lecture, but this is a fact that you need to know. Insulin, potassium needs insulin to enter inside the cell, and insulin needs potassium. So potassium and insulin, they need each other to enter inside the cell. So in this case, where you have no insulin in the body, you're going to have very high levels of potassium in the blood, but this potassium can't enter the cell. That's why intracellularly, this potassium is very low. Because remember, potassium needs insulin to enter the cell, and insulin at the same time needs potassium. So when there is no insulin, potassium doesn't go inside the cell and it stays in the blood. And probably from what you know in probably from what you know from CVP, when there's hyperkalemia in a very, very high levels, it could lead to arrhythmias and cardiac arrest and death. So that's why ketoacidosis or diabetic ketoacidosis is a very, very, very serious complication. That's why it's very high yield. That's why the doctors always want to ask about it because it's such an important concept because it leads to death. Okay, like it's the biggest thing that could happen. Now, when does diabetic ketoacidosis happen? It happens in type 1 diabetic patients who are not taking any medications. So basically, they're not taking their insulin. So there is no insulin at all, right? It could lead to diabetic ketoacidosis. That's the first case. The second case, in a type 1 insulin in type 1 diabetic patients who suddenly have he's going through a period of his life where there's increased stress. Now, when there's increased stress in your life, basically you need more insulin. That's just a random fact. Okay, just know it. When there's stress, when you are in a stress position, your body needs more insulin. Now, you're just taking the normal dose and you're not taking an increased dose because again, remember, you're just taking the insulin doses that the doctor has prescribed for you. Your body is not increasing insulin. You're just taking it by needles, right? So now you're taking a low dose for your requirement because you have increased stress. So your body needs more insulin than you're actually giving it. So it could lead to ketoacidosis. And so many other things. Basically, anything that leads you to need more insulin, right? But you didn't adjust your therapy. So whatever you go through in your life that basically makes your body needs more insulin, but you didn't adjust your basically your dosage. You're still taking the normal dosage, even though now you need more insulin, but you're taking the same dosage. So basically you have less insulin than you should, which could lead to ketoacidosis. That's why it's very, very serious condition that probably you will get asked about. I'm pretty sure, Kaman, this is a concept that Dr. Ahmed, Dr. Yaqin is going to ask about. I'm very, very sure he's going to ask about it. So please know it very well. Okay. So what are the symptoms of ketoacidosis? Psychosis, which is basically, it's like hallucinations. You start seeing things. You can't think well. Basically, your brain is not functioning as it should. Deep, rapid breathing, as we said, due to hyperventilation because you are in an acidosis stage, as you took in CVP. Remember, when you are in an acidosis stage, you start ventilating more than you should, basically to get rid of CO2 and put your body in like basically, yeah, to get rid of CO2, which is an acid. Third thing, which is dehydration. These are the main three symptoms: dehydration, psychosis, and rapid breathing. Just know them. Psychosis, as I said, hallucinations, you can't think well, you start seeing things, whatever. Deep rapid breathing because you are in an acidosis state, and dehydration. Okay? Know these three very well. Okay. Okay. Now we reached the last two slides. Guys, is there any questions about ketoacidosis? Or is it clear? Okay. Everything appears good. Can you just recap hyperkalemia? Okay. Okay, basically, what you need to know, okay, your body is not really losing potassium. Okay, potassium is there in the body. You're not losing it. Okay, but the problem is some of the potassium should be inside the cell, right? And some of the potassium should be outside the cell. What's happening when there is no insulin? The potassium can't enter the cell. Remember, for potassium to enter the cell, it needs insulin. And also for insulin to enter the cell, it needs potassium. So they both need each other to enter inside the cell. Now, in the case where you don't have insulin at all, or insulin is low, a lot of the potassium that should be inside the cell is not being inside the cell. So it's outside the cell, right? It's in the blood, which put the body in a hyperkalemic state because all the potassium is in the blood. Like almost none of it is inside the cell. Obviously, there's still like some percentages inside the cells, but less than they should. That's why you're gonna have hyperkalemia because more potassium is in the blood, even though the cells have no potassium. Okay, this happens when there's no insulin. Now, when you give insulin, okay, this insulin is gonna go and enter inside the cell using these potassiums that are inside the blood, which is going to basically fix this hyperkalemia. Now, what happens if you never fix it? Basically, you never give insulin. Hyperkalemia or increased level of potassium inside the blood could lead to arrhythmias and cardiac arrest, which could lead to death, if that's clear. Is it clear? Okay, I guess. Thank you. So, is hyperkalemia clear or not? Or do I need to? Okay, great. Okay, now hyperosmolar hyperglycemic state. Now remember, ketoacidosis happen in type 1. This hyperosmolar hyperglycemic state happens in type 2. Now, Salaha, I don't know if it's important because the doctor like just read it, but I'm gonna explain it as good as I can. But me personally, I don't think it's that high yield. So just know it. Maybe you get asked about it, but like don't go into details. What happens is, again, because you have very high level of glucose in the blood, basically the blood osmolality increases, okay, which usually happens when you are an elder patient, okay, who have type 2 diabetes for such a long time, okay, and you can't drink water. So basically you can't increase the volume of the blood and glucose is always there, which increases the percentages of glucose, right? Which basically increases what I mean, the osmolality of the blood. And remember, glycemia, hyperglycemia, it's leading for glucose to go into urine, and so you're losing also fluids in the urine. So your body is dehydrated. So your body is dehydrated, and you're not able to drink enough water because you don't have access, whatever, right? So that's gonna put your body in a very hyperosmolar, hyperglycemic state, which could lead to symptoms such as thirst, polyuria, lethargy, sometimes seizures, coma and death if it's untreated. Again, as we said, dehydration, hypovolemia could lead to those. You're going to have very high levels of serum osmolalities, way higher than normal, and very high levels of glucose in the blood, as we said. The treatment is just to give fluid because, again, you're dehydrated. Give fluid, give insulin, you should be fine. Is it clear? It's just basically you have type 2 diabetes and you can't basically you're in a state where you're dehydrated because you can't drink enough water or you can't get enough fluids, and you're still losing water in the urine because there's glucose in the urine which is attracting water. So basically your body is losing water, dehydrated, losing water, dehydrated. If this keeps going on, it's going to lead to death. As simple as that. I don't think you need to know more details. Just know that the serum osmolality is going to be stupidly high. Also, you're going to be very hyperglycemic, but there is no acidosis. Ketone production, there is no ketone productions because there is insulin in the body. There is insulin, so ketones won't be produced, unlike type 1 where there is no insulin at all. Clear? Great. Again, these two concepts I don't know if they are actually important, but the doctor went over them, so I'm just gonna over them. The first one, which is a glycogonoma, basically it's a tumor of the pancreatic alpha cells. If you remember, alpha cells in the pancreas, they produce glucagon, which is the opposite of insulin. So when you have tumor there, logically, you're going to produce more glucagon than you should, right? Now, what does glucagon do? It increases the levels of glucose in the body, in the blood, right? So you're going to be hyperglycemic, good diabetes, DVT, declining weight, depression, dermatitis. I think what you need to know from these two diseases that glucagonoma is basically a tumor of alpha cells. That means you're going to have overproduction of glucagon, which is going to put the body in a hyperglycemic state. On the other case, insulinoma, where you have tumor in the pancreatic beta cells, you have overproduction of insulin, which is going to put the body in a hypoglycemic state. I think this is the most important thing to know about these two tumors. I don't think he's gonna ask about them, but again, I can't tell you. I can't give you a definitive answer. No, خلاص, he's not gonna ask about them. He could, because it's in the slides. So just know that if he tells you there's a lot of glucagon for some reason, right, and there is diabetes with depression or something like declining weight, it's most likely a tumor in the pancreatic alpha cells. If there is overproduction of insulin, even though there is no resistance, but there is overproduction, which is leading to hypoglycemic state, then it's probably a tumor in the beta pancreatic cells, which is insulinoma. The names are very easy. A glucagonoma, basically overproduction of glucagon. Insulinoma is overproduction of insulin. Again, there's the Whipple trait, which is low glucose, low blood glucose, have yeah, basic and like Men-1 syndrome. To be honest, we didn't take them in our first year, but I guess the doctor put them for you. You got taught by a different doctor, so I guess just know them. Just know, as I told you, overproduction of glucagon, overproduction of insulin, and all the symptoms that happens after that. There's not a lot to explain here. Okay, so we're done with the lecture. Is there any questions regarding any concept in the lecture? All clear? Okay. You're welcome. Thank you all for attending. Anyone who attended here or anyone who's seeing this over YouTube, thank you all for watching the video or attending the live. Again, this is my WhatsApp number and this is my email. Uh, you can always contact me regarding any question in this lecture or regarding, to be honest, anything in EndoRepro. EndoRepro is my favorite block info. It wasn't second year for us, but yeah, and yeah, it's a block that I really love. So, any questions regarding that block? I'm always open to questions. And yeah, thank you all for attending. I appreciate it. I hope it was useful and helpful. You can stop the recording if you want.